Greetings. Let me share with you about this patient with a polyp around the appendicular orifice that was biopsied, and the patient was told to have a follow-up colonoscopy in a year. And the patient became uncomfortable and decided to come to our institution for further management. As you can see, the patient has done an excellent job with her colon clean out, and you notice a flat lesion occupying the rim of the appendix, almost half of the circumference, and it doesn't extend too much onto the cecal side, and the pit pattern has that starry appearance indicating that this is a sessile serrated adenoma, and I don't see any features to suggest advanced pathology like dysplasia. My first step was to see whether the polyp has extended deep into the appendicular orifice. And this is what I have discussed with the patient before the procedure. And as you can see, I'm pleased to note that the depth of extension is limited to the circumference of the opening and does not go deep in. And this was, as you can see, figured out with the use of a biopsy forceps and gentle application of pressure to look at the deep end of the appendicular orifice. So I was convinced that this was something that we could resect by endoscopy means without additional need for appendicular resection by a surgeon, or in other words, appendectomy. In the past, when I dealt with these lesions in the early part of my career, I used to inject and lift the lesion away from the underlying muscularis propria, similar to what I used to do for other colon polyp resections. But I've noticed that whenever I did that, my injection never went deep enough and created a mucosal bleb, which easily ruptured and made my resection much more technically challenging. Since then, whenever I see a lesion like this, I stopped injecting solution to lift the lesion. Instead, I use hot snare resection, and in this case, I tried to apply the snare from the right side, as you can see, but decided that was not the right angle, so I decided to go from 12 o'clock down. And my initial application, I felt that I may not be able to grasp the entire lesion, so I repositioned the tip a little bit deeper into the appendix opening and then closed. I set up electrosurgery unit, OB unit, Endocut Q313, and I had 2 clips already open and ready to go if in case it caused bleeding. It is almost to the point of cold snare cut, and at that tight squeeze, I gently tapped on the yellow pedal for a fraction of a second to deliver just cut current without any coagulation, so that the depth of injury from the electrosurgery is limited to the submucosa without extension into the muscularis propria. You know that this is a very thin portion of the colon, and it is important to limit the damage. And if in case there were to be bleed, I had my clips already ready and open to manage that bleeding. The next step was whether I ended up with a complete en-bloc resection. So with the cap-fitted endoscope that I started my procedure, I was able to document that my resection was complete without any residual lesion on the deep side of the resection. And I wanted to confirm it by using the snare tip and try to examine it a little bit more carefully. So here I'm trying to examine and convince myself my resection was complete in terms of the lateral margin being clear of any polyp, and the deep margin looks good. So that's what I've been trying to do here. So the next step is whenever you have an SSL-serrated adenoma lesion like this, I always try to ablate the edge because these polyps are so subtle. And before I ablated the edge, I used the snare tip to look on the deep side of the resection. This is what I'm doing right now. I'm gently pressing and trying to define the deeper side of the resection. And once I was convinced that it was clear, I used a soft tip coagulation effect for 80 watts to ablate the normal looking edge for a few more millimeters so that we don't have to deal with any recurrence down the road. So as you can see here, as you carefully examine, the edge towards the 3 o'clock of the resection was not ablated before. So I'm trying to deal with that right now by trying to move that fold away and then try to apply the snare tip soft coagulation. So now once you complete the ablation, you want to make sure that you close the defect with clips. And whenever you're doing a complicated resection, you want to make sure that your clips are already available in the room, ready to go. This is something you need to get into the habit. Sometimes your assistants may have not stocked the room, and then you end up with a problem, and then you can't really take care of an issue that happens. So here I use the resolution clip to close the defect, and I wanted to achieve deep approximation. And when I'm doing the clip closure, I try to insert one arm of the clip into the appendicular orifice and the other one on the cecal side, and try to close that rim of tissue and achieve a secure closure. So having done 2 clip applications, the third clip, in this case I used a Microtech clip because the clip has slightly narrower jaws, and that can fit in between those 2 resolution clips. And I used a 16 millimeter clip to get enough depth into the appendix orifice for closure. And after closure, we came out without examining the rest of the colon. to avoid any clip disruption. And this patient has already had a beautiful exam by an outside gastroenterologist whom I've known for many years. Thank you.